Good evening, friends, colleagues, people on YouTube who are interested in learning about pseudobulbar palsy. My name is Brandon Larson. I'm a graduate clinician at the University of Northern Colorado, and welcome to my voiceover PowerPoint. Now, pseudobulbar palsy is a neurological disorder that is characterized by upper motor neuron degeneration. These are first-order neurons that originate in the cortical areas of the brain. Now, it can be caused by two different lesions, basically a unilateral upper motor neuron lesion or bilateral damage to the cortical bulbar tracts. So here I have a picture of the pyramidal tract system. Pseudobulbar palsy is when a lesion occurs up here, these first order neurons, before they synapse at the cranial nerve nuclei. Anything in this area, when a lesion occurs down here, this is where we'll see bulbar palsy, which is often confused with pseudobulbar palsy because despite their differences, there are a few shared characteristics. So there are many causes of pseudobulbar palsy. The most prevalent would be a stroke, then demyelinating diseases such as multiple sclerosis, other motor neuron disease, brainstem tumors, which would be high in the brainstem before those cranial nerve nuclei, as well as traumatic brain injury and even syphilis, but in very rare cases. As I promised, I said we would contrast bulbar palsy. So both of these disorders involve the cranial nerves 10, 11, and 12, but pseudobulbar palsy also involves cranial nerve 5 and 7. Because of this, there's going to be some jaw problems and more exaggerated facial problems. Now, pseudobulbar palsy will lead to increased reflexes, the jaw jerk, an exaggerated gag reflex, and this could also be present in the limbs as well. You'll see hypertonia of the tongue. You'll hear a raspy voice with pseudobulbar palsy, which is something you'll hear in bulbar as well. And it's often associated with spastic dysarthria. A bulbar palsy, on the other hand, like I said, it's a lower motor neuron problem. It only involves cranial nerves 10. We'll see diminished reflexes. There'll be tongue fasciculation, hypotonia is another way to put it. But raspy voice will also be associated with bulbar palsy as well due to the involvement of the vagus nerve, or cranial nerve 10. Bulbar palsy is associated with a more flaccid dysarthria. Again, I put these two X's here to show you that this is likely where the lesion will occur for bulbar palsy. Anything above the brainstem or very, very high in the brainstem will be associated with pseudobulbar palsy. So there are many speech characteristics of pseudobulbar palsy that go hand in hand with the characteristics found in our patients with spastic dysarthria. In terms of respiration, the volume for inhalation and exhalation will be reduced. There'll be a smaller vital capacity. The ability to sustain vowels for a long period of time will be greatly reduced. There'll also be some laryngeal issues, obviously because of the involvement of the vagus nerve. So we'll see increased subglottal pressure, more glottal resistance. There'll be more shimmer and jitter in the voice. The vocal folds will hyperabduct. This is both the true and false vocal folds, mind you. We'll hear a strained, strangled voice and a harsh voice as well. Patients that have a bilateral lesion will often present themselves with more hypernasality and nasal regurgitation as well. Now, patients with pseudobulbar palsy are likely speak at a slower rate. Their prosody will definitely be affected. They'll use shorter phrases. Their pitch will be lower, and they'll speak with a monoloudness. In regards to articulation, consonant imprecision is frequently seen in these individuals. There's reduced stress, and this is due to articulatory and resonatory incompetence. So when we're assessing our patients with pseudobulbar palsy, we're really going to want to look at the functions of cranial nerves 5, 7, 9, 10, 11, and 12. During the oral mechanism exam, we're really going to want to look at jaw and lip closure, tongue mobility and strength, the gag reflex, are they able to elevate their palate? When they're performing their AMRs, we're going to see some slow alternating motion rates. And cognitive status, their alertness is also something we should take into consideration, and I'll touch on that a little bit later. So, some things associated with pseudobulbar palsy. The tongue is often paralyzed and unable to protrude at all in the most severe cases. Again, we're not going to see any fasciculation here. It's going to be hypertonic. The weakness of the tongue, that will be more of a bulbar issue. So lack of palatal movement is something we're going to want to look for. Is our patient persistently dribbling? Do they have exaggerated reflexes, not just in their face, but in their limbs as well? Are there any swallowing problems, that dysphagia? Is their face paralyzed? And something very interesting about this disorder is that it often causes emotional lability, which is uncontrollable laughing or crying. And this is related to outward expression and not our patient's internal state. For instance, they may laugh at something very sad and they may cry at something very funny. And they may just be a case of over-exaggeration. But this has to do with their cognitive status. So, before we even get to speech and language, it's important to really treat that dysphagia. Nutrition will always take precedence over speech and language services, but don't worry, I will touch on those later. So I'm not going to get into too much detail for dysphagia, but biofeedback and teaching compensatory strategies are just a couple ways to improve swallowing. There's also ways to modify the diet, giving them easier things to swallow, and in some cases, Botox injections into the vocal folds will help with this. And we can also see that help with phonation. And if all else fails, a laryngectomy may have to be conducted if they are unable to improve after a swallowing treatment. So when we're treating pseudobulbar palsy, we're really going to want to fix the respiration issues. And this can be done just by teaching some behavioral methods. Just by rotating and tilting our heads in certain ways, we can raise our fundamental frequency. Initiating utterances from a higher lung volume, we want to teach our patients to do that because more air generally equals more intelligibility in this case. Relaxing muscles of the neck, head, and shoulders while inhaling and exhaling can also help improve the hyperabduction of vocal folds. By teaching our patients to improve their posture when they speak and giving them breath support by pushing on their abdominal muscles while they're exhaling will also help. We want to teach them to begin phonation after a breathy sigh. This is a strategy that can help improve their intelligibility. And I know I said something a little contradicting earlier about wanting to increase airflow, but we got to be considerate of the fact that too much airflow can actually increase tension of the vocal folds. So we can use methods like biofeedback with EMGs and visi pitches and nanometers to help clients to discover the correct amount of air that they should be using while breathing. A visi pitch will also help them see their own pitch, range, and intonation. And for severe spasticity, again, we could use Botox injections. It might help with their phonation. So, articulation treatment. Realistically, we should be looking at gentle approximations and vowel productions first. We're going to want to start with the vowels and move on to some simple consonant sounds with the h and other liquid consonants and simple CVC shapes. Again, we can use biofeedback to help patients be aware of their own tension when articulating specific words and consonants, and the nasometer may be used to help patients be aware of their own nasal emissions. And the strengthening exercises that are often associated with articulation treatment are inappropriate for this population. Why? Because there's already increased tone from the upper motor neuron damage. The spasticity will not require any strengthening at all. They're going to be hypertonic. So by doing strengthening exercises, we're going to be increasing tension, which can lead to greater consonant and precision. Prosthetics are often used. A palatal lift may help compensate for velopharyngeal insufficiency. Girdling or wrapping around something around the chest can be used to help during exhalation to provide breath support. This will help with phonation as well as harshness. Boards attached to wheelchairs, patients can lean into them during exhalation. This will also improve their respiration abilities for articulation. Here's some amazing YouTube videos about pseudobulbar palsy. It looks like my time's just about up, but I can put these YouTube links up. The first one's about living with pseudobulbar palsy. It's a first-person account. The video is really well done. It's a fictional video, but I really enjoyed it. I thought it was very informative. The second video here is an excellent video contrasting bulbar and pseudobulbar palsy. And the final website is sort of Britain's answer to WebMD. It provides some basic facts about pseudobulbar palsy, and it's just a great starting point. But I really appreciate your time. I'm sorry for going slightly over. If you all have any questions, please let me know. Here's my reference page. You can either contact me on YouTube or by email. Again, have a wonderful spring break. Thank you so much.